Jenna, I like your lights.
So I just posted a link, like a sign-on like a Google Doc on Facebook, and also sent it out via email. So if y'all, as y'all get a chance, if y'all wouldn't mind going and putting your name and TTUHSC email on there. Promise I'm not going to send y'all anything. It's just so that Dr. Perrin, she like keeps track of like resource using or whatever. So if you wouldn't mind doing that for me, and then we'll get started at like 5 minutes after. I usually wait like 5 minutes for all the stragglers to come in case, so that all the people who run perpetually late like me have time to get in. So about 7:05 we'll start, just FYI. Also, sorry, I apologize. I have a little bit of a cough, but not COVID. I've been vaccinated, both of them. But while we're waiting, I got a few people asking me today, and I don't know if I replied to everyone, but this is supposed to be recorded. So assuming that that all works out or whatever, if you want a copy of the recording afterwards, just shoot me an email and I'll get you, I'll give you the link to it. I'll probably end up uploading it on Google Drive and I'll just send you the link to that. So if you want a copy of that, shoot me an email and I'll reply with that. And then if you're just coming in, please make sure you sign in on the Google Doc. Let's see what else. Oh, and I will post, I'll just go ahead and post the PowerPoint to Facebook afterwards. So if you want a copy of that, I'll also email it out so you can get it that way. And let's see, what else? Y'all can all hear me okay, right?
Yes.
Okay, perfect. Okay, awesome. And I'm really bad at checking the chat. So if you have a question or like a comment or whatever, want to stop me for some reason, it's probably best to just come off of mute and get my attention. I'm really bad at checking the chat. So
I might have missed it, but is there a handout for the session?
no, I have a PowerPoint that I'm going to use and I'll post that to Facebook afterwards. It has some questions at the end with the answers, so it would kind of defeat the purpose of going through that if I posted it before, but I will post it after. So I apologize for those of you who like to take take notes on the slides themselves or whatever. But anyhow, so
Okay. Thank you.
yeah. Any other questions while we're waiting? We'll get started, like give them 2 more minutes for anybody coming in late. But. And just kind of, I know I put it in the Facebook post, but just kind of to recap, it'll be about 45 minutes didactic wise, and then we'll do about 15 minutes. I have some questions that are Dr. Presley style. Did Dr. Presley get to talk to y'all this year? I know he technically retired last year, but did y'all get to meet Dr. Presley?
Yeah, he's around.
Okay.
Pretty much every day.
Oh, great. Oh, okay. I love him. He's one of my very favorite professors. So I don't know how y'all feel about him or not, but okay, good. Okay. I'm glad he got to give a lot of the lectures. Yes, I love him too. And then y'all had a diagram workshop today, right? Is that correct?
Yes, this morning.
Okay. Alrighty. So hopefully this won't be too redundant. If at any point this becomes not helpful to you, you won't hurt my feelings by leaving or anything like that. I'm not offended by that. The last thing I want to do is waste y'all's time because I know how valuable time is in medical school. So don't feel bad if you decide to go. It will not offend me. Okay. All right, give them 1 more minute and then we'll get started. And y'all's test is Friday, right? Okay.
Yes.
Cool, cool, cool. Okay. So I will go ahead and I will share my screen here with y'all and we will get started. Okay. Y'all just see, y'all don't see presenter view, right? It's full screen for y'all, is that correct?
Yes, it is.
Okay, cool, cool, cool. Okay. Alrighty. So we'll get started. There's a lot of you, so I hope this is beneficial, but in case, like I just said, if at some point it becomes not beneficial, you won't hurt my feelings by leaving. And also, if you came in a little bit later, make sure that you do go and sign in on the Google Doc. And then also, if you have a question or something, just stop me. You don't have to wait till the end or anything. Just go ahead and interrupt me. And I'm not very good at checking the chat, so. Okay, and this is, so the way this is set up, so I'm going to go through and I'm going to kind of talk about the, the rationale to why each thing, why each part of the gut diagram kind of is the way that it is. And then at the very end, we'll kind of go over a little bit of an overview of it, and then we'll work on some questions. And so the idea with this is that hopefully, because Guyton diagrams can be very confusing and kind of amorphous a little bit. So hopefully I'm going to give you some kind of more logical ways to kind of progress through it and kind of a systematic way to approach it. Because anytime you approach things systematically, you reduce the likelihood that you're going to leave something out or miss something or, rationalize or reason through something incorrectly, I guess. So hopefully that will help. And let's see if there was anything else. Oh, and so it is kind of designed to be interactive. So by all means, if you want to sit there and just watch and listen, that's totally fine. And I'm cool with that. But if at least a few people could play along with me, it makes it more fun for me. And hopefully it'll be more beneficial for you that way. And then I will post the PowerPoint afterwards. I'll post it to Facebook and also send down an email. This is supposed to be being recorded. So if you want a copy of it afterwards, just email me. Okay. So now we'll start. So when we're talking about Guyton diagrams, there's 2 parts to a Guyton diagram. And so what are those 2 different curves that we see on a Guyton diagram?
Cardiac function curve and vascular function.
Exactly. So we have our cardiac function curve, we have our vascular function curve, and we're going to break it down and talk about each one individually. So first, we're going to start with the cardiac function curve. So when we're looking at a cardiac function curve, here it is right here. So there's 3 things that can affect the slope, and only 3 things. So what are those 3 things that affect the slope of a cardiac function curve?
Heart rate, contractility, and total peripheral resistance.
Absolutely. Wow. Okay. Yeah. So yes. So you have contractility, which we also refer to that as inotropy, right? And Dr. Tinner, y'all have had him, right? When I say inotropy, you say, y'all not had that yet?
We haven't had him yet.
Oh, okay. Well, he'll tell you when I say inotropy, you say calcium is what his little kind of little catch line. So, and that's because calcium is what mediates inotropic effects. So contractility is one of them, or inotropy. Total peripheral resistance is another one, like you said, and also heart rate. And so the total peripheral resistance on here, the reason I said the if only right here is because total peripheral resistance is the one thing that's going to affect both the cardiac function curve and the vascular function curve. And so each one is going to respond to it differently and independently of each other. And a lot of times what will happen because of that, because it's affecting both things, there's going to be reflexes that occur in response to that. So like if you increase total peripheral resistance, then a lot of times you're going to have a reflex tachycardia. And so when you're looking at the problem, it's important to realize whether the problem is asking you to take into account like the reflexes that are going to occur and everything in total. And so we'll kind of see that on a few of the questions when we go through that. Or if the problem is just asking you in isolation, if I change this thing, then what effect is that going to have on the curves in the Guyton diagram? Okay. And so we'll see some questions like that too. So that's the reason I put the if only right there. Okay. And so where do we get the cardiac function curve from? What is it derived from? Anybody? There's a law. What law is it derived from?
Frank-Starling?
Yeah, the Frank-Starling law, exactly. And so what does the Frank-Starling law deal with?
Stretch.
Yeah, so it's a length tension relationship, right? So when at the simplest kind of form of it, when we're talking about skeletal muscle, the more we stretch it, so the greater length, then generally it should be the greater tension that we create, the greater like the more force it's going to create when it contracts. And so that's the heart, just like is a muscle, albeit cardiac muscle, not skeletal muscle, but it functions, the physiology of it is similar to the skeletal muscle. And so that's where we get the cardiac function curve from, is from that Frank-Starling law. But just like with the Frank-Starling law, so what happens if you stretch that skeletal muscle too far? What happens?
There is
The actin and the myosin don't overlap as well anymore.
Yeah, exactly. You kind of break it in effect, right? It's kind of like a slinky. Once you stretch, if you stretch it too far, it loses its recoil, right? You kind of have broken it. And so the same thing can happen with the heart when we have damage to the heart. So if the Frank-Starling law dissociates, that's going to really be the only thing that shifts the cardiac function curve, okay? And that happens when we have damage to the heart. So what are some examples of things that would damage the heart, or instances where the heart would have a dissociated Frank-Starling law?
Would an ischemic effect or attack affect it?
Yeah, exactly. So, well, if ischemia goes on too long, you get necrosis, right? So you're losing muscle there. So that would have an effect. And especially when you start getting fibrosis and scarring, that's going to dissociate the Frank-Starling law. If you're in heart failure, which can be secondary to those necrotic changes, or it can be for other reasons. But when you're in heart failure, that's notorious for having a dissociated Frank-Starling law as well. And so we'll look at that a little bit later too. Okay. So the next thing I want to talk about on this curve is, so there's a lot of different things that you can see here on the x-axis. And if you're not aware of them, then it can really throw you off when you're looking at a question. So right now we have right atrial pressure on there. What are some other things that we can see down here on the x-axis of our curve as a label of units down there?
Preload.
So preload, yeah, that's something you can see down there. Absolutely. What else?
EDV, EDP.
Yeah, so in diastolic volume, in diastolic pressure, and there's one more thing that we can see down there.
Central venous pressure.
Central venous pressure, absolutely. So a lot of different things. So right atrial pressure and central venous pressure, for all intents and purposes, are going to be the same thing. Why is that?
Because cardiac output has to equal venous return.
So you are correct that cardiac output must equal venous return. However, that is going to be over here on the y-axis. Why does right atrial pressure equal central venous pressure? So central venous pressure would be what you find in the like the vena cava. Why are those two equal?
There's no valves, so the pressure is
Absolutely. Yes, absolutely. There's no valve between the right atrium and the vena cava, so essentially it's all one continuous unit, right? So the pressures there should be equal, at least for the purposes of our Guyton diagrams. And so then in diastolic pressure and in diastolic volume, those are not equal to right atrial pressure, central venous pressure, but they are directly proportionate to it. So you could see either of those two things down there, and we call both of those things can be referred to as preload on the heart. Okay. Alrighty, so how about on the y-axis? So we most often will see cardiac output here, but what else can we see on the y-axis? We already kind of mentioned one of them.
Strike volume.
Stroke volume, yes, we can. Huh? Sorry, was that not what you said?
Yes, no more what it was.
Okay, so yeah, we can see stroke volume. What was the other thing that we could see on there that we kind of already mentioned?
Venous return.
Venous return, there we go. Yeah, so cardiac output, as Maria already pointed out to us, always assuming that we have a functioning circuitry, right, must equal venous return, because what comes out must come in, or else you're going to have a buildup, a backup somewhere, right? So that happens in heart failure. But stroke volume, why? So stroke volume is not equal to cardiac output or venous return, but it is directly proportional to those. Why?
Because you're only ejecting a fraction of your end diastolic volume.
Cardiac output equals heart rate times systolic or SV, stroke volume.
Yes, that's right. So the first thing I'm sorry, I forget who said what first, but you're not wrong. You do only eject a fraction of your end diastolic volume. You're not wrong. But the reason that stroke volume is directly proportional to cardiac output is because, just like Christina just told us, so cardiac output, oh, I'm so sorry. It's hard. I'm writing with a pad, like a little mouse pad with my fingers. Anyways, but cardiac output is equal to stroke volume times heart rate. Absolutely. So if any increase in stroke volume is going to, I promise my handwriting in real life is much better than that. So any increase in stroke volume is going to cause a directly proportionate increase in cardiac output. Yeah. And so if we do have stroke volume as the measurement that we use on this y-axis, one of these three things over here on the slope, affecting the slope, cannot account for any changes that we see. So if I have stroke volume over here, which of these cannot account for any changes that I see in the slope of the cardiac function curve?
Heart rate.
Heart rate, exactly. Why?
Because it's only one beat. That's how much blood you're ejecting per beat in stroke volume.
Yeah, so heart rate has no direct effect on stroke volume, right? They're two independent variables here. Contractility obviously affects stroke volume because less squeeze, less stroke volume, right? And total peripheral resistance will also have an effect on stroke volume, because if you're pushing against more resistance, you're not going to push as much out, right? But heart rate, exactly, it's independent of stroke volume, so it has no effect. So if you see stroke volume over here, heart rate can't account for any changes in slope. Yep. And so a couple things before I move on, a couple things I want to point out here. So equations are going to be pretty important for the exam. Not so much that you're going to have to calculate anything per se. There might be like a few calculation questions like Nernst equation type stuff, but they're important because the concept behind them, you need to be able to, and we'll go through the important equations relevant to Guyton diagrams as we go through, but you need to be able to kind of be able to reason through, okay, if I increase this and I don't change this, then what's going to happen to this? You kind of need to be able to reason through that qualitatively, not necessarily quantitatively. And then another thing that I was going to say, so with the kind of the different things you'll see on the y-axis or the x-axis and stuff like that, it doesn't have to be intuitive, and it doesn't have to necessarily make sense, but you need to understand that it's there and why it's there, if that makes sense. Okay. All right, we good so far? Okay. All righty. Okay, is there noise on my end? Somebody said, what is the noise? But
Yeah, I think it sounds like something's like rocking and like tapping your computer maybe.
oh, okay. Maybe it's because I'm, okay, here, let me see if I, hold up. Maybe if I move it to another surface. Give me 1 second. Let's see. If I put it on right there, is that any better? Is the noise still there?
I don't hear it now.
You don't? Okay. All right. Perfect. Okay, cool. All right. Okay, so now I'm going to go through on each slide. Let me minimize that again. So what I'm going to do is I'm going to go through each of the different effects. We're going to kind of talk through them in a little bit more detail, okay? So first we're going to talk about contractility. It's probably the easiest one to understand here. So at the molecular level, what happens to mediate changes in contractility? What is going to have what's going to cause that inotropic effect?
Calcium.
Calcium, yeah. So we get an increase in calcium coming into the cell. We get an increase in contractility. And so what effect then will that have on cardiac function? Increased contractility increases what?
Longer action potential, longer plateau of the depolarization.
So you're not wrong. I'm thinking more like in general. So like stroke volume, what is it going to do to stroke volume? If I increase contractility.
Increase.
Yeah, I increase contractility, I increase stroke volume, and if I get an increase in stroke volume, then what's the effect that's going to have on cardiac output?
Increase.
Increase, yeah. So it's really kind of, this one is fairly straightforward. So increased contractility, I increase stroke volume, and because heart rate times stroke volume equals cardiac output, then I get an increase in cardiac output. So the slope for contractility will always move in the direction of a change in contractility. So if I increase contractility, I get an increase in my slope like that. And if I decrease contractility, I get a decrease in slope. So that one's pretty straightforward. So, but if we look at TPR, that one's a little less intuitive. So at the level of the vessels, what is happening when I have an increase, or if I have an increase in TPR, what's happening at the level of the vessels?
The arterioles are constricted.
Absolutely. So I get a constriction of arterioles. And so what then, so the, what effect is that going to have on my, on my resistance if I increase the constriction of arterioles?
Resistance is increased.
Yes, and it's increased because when I increase constriction of arterioles, what am I doing to my radius?
Making it smaller.
Yeah, I decrease my radius. And so Passai's equation, do y'all remember that one? It's the resistance is proportional to the viscosity. Here, I can write it on the board. So Passai's equation, that's resistance, is going to be, that's proportional sign right there. That's not a very good one, but that's what it's supposed to be, is directly proportional to the viscosity, right, of the blood times the length of the vessels, the total length of the vessels, divided by radius to the fourth, right? Y'all, does that one look familiar? Maybe?
Yes.
Okay, yeah. So you can see that even small changes in the radius have a really, really big effect on resistance. So if I increase my, or I'm sorry, if I decrease rather, so if I decrease my radius, then I'm going to increase my resistance by a pretty good amount. Yes. And so if I increase my resistance, so if we, what effect then will I have on my cardiac output?
Decreased.
It'll decrease. And so, and the reason why is because of Ohm's law. So Ohm's law, what is that one?
Change
V
in
equals IR.
V equals IR, yeah. So V equals IR. And so when I'm talking about Ohm's law in relation to the cardiovascular system, so what does V represent?
change in pressure.
Yeah, V instead of, so normally it's voltage when we're talking about the cardiovascular system or fluids, it's going to be pressure. And I is going to be what? Normally current, but go ahead.
Flow.
Yeah, flow. And so for the purposes of our cardiac function curve, we can think of it as cardiac output. And then resistance is still resistance. So when we're thinking, so TPR has a different effect on both the heart and on the vasculature. So when you're thinking about what effect it's going to have, you're going to think about what that system controls. So if we're talking about the cardiac function curve, so we increase our resistance. And so out of pressure and cardiac output, which of those can the heart directly control?
Output.
Output, yes. So that's the one that's going to change. So pressure, for the purposes of the cardiac function curve, is going to stay constant in this. So if my resistance increases, my pressure stays constant, what has to happen to my cardiac output?
It has
It has to what?
Decrease.
Decrease, yeah, exactly. So that's, so this is the mathematical reason behind why the increase in total peripheral resistance causes a decrease in cardiac output, okay? So you don't have to be able to reason through that every time you look at a Guyton diagram, but you do have to, it is important to know where it came from, because there will be some problems that ask you to recall that sort of depth of understanding, if that makes sense. So the summary basically for TPR is that increases in TPR are going to cause decreases in the slope, and decreases in TPR are going to cause increases in the slope. So it's the opposite direction of the change. Cool. And then so for heart rate, that one is simpler again, but there is a catch to it. So what do you have to determine about the increase in heart rate before you can determine which direction the slope is going to change?
If it's still within the normal range of heart rates.
Exactly. So you have to determine if it's a mild or a physiologic increase, or if it's a drastic or pathologic increase. So a mild increase would be going from like my normal resting 60 beats per minute to 120 when I'm jogging. That would be a mild physiologic increase. A drastic pathologic increase would be like, say, I have supraventricular tachycardia, and so I go from 60 beats per minute to like 180 beats per minute. That's going to be pathologic, and so the slope will actually decrease. So mildly increased heart rate, because heart rate times stroke volume equals cardiac output. If we increase heart rate, then we're going to increase our cardiac output. So that one's pretty straightforward. But then if I have a drastic increase in my heart rate, what's going to start happening to my stroke volume at a certain point?
It's going to decrease because you're going to compromise ventricular filling.
Absolutely, yes. So there comes a certain point where my heart's beating so fast that I'm beginning the next stroke before I fully fill up with blood. So at a certain point, which occurs about around like 140 or so, you're going to start, your stroke volume is going to decrease to the point where additional increases in heart rate are not going to be able to overcome that decrease in stroke volume. And the overall result is going to be a decrease in cardiac output, yeah? So drastic increases in heart rate are going to decrease the cardiac function, the slope of the cardiac function curve. Cool?
You said that was around 140 beats per minute.
That's about where the shift happens. They're not going to give you like a number like really like super close in the middle. They're going to make it pretty clear that it's either physiologic or drastic. And a lot of times you'll be able to tell from the problem too. Like if the guy's just working out, they're trying to signal to you that that's a physiologic increase. But if they're saying like, oh, he's in supraventricular tachycardia, or he's symptomatic, like maybe he's having palpitations, or he's sweating, or he passed out, or something like that, then they're trying to, or if he's like losing blood, then they're trying to signal to you that's pathologic. So you can also get a little bit of a flavor of that from the question.
Cool, thanks.
Yeah, I definitely over-answered that. I apologize. Okay, so to summarize changes on the cardiac function curve. So changes in contractility move the slope in the same direction. So increased contractility, increased slope. Changes in heart rate change the slope of the cardiac function curve in the same direction as the change. So increased heart rate, increased slope, decreased heart rate, decreased slope, unless it's a drastic pathologic change, in which case it's a decreased slope. And then TPR always changes the slope in the opposite direction of the change. So increased TPR, decreased slope. Yeah? And so the thing with the cardiac function curve, you can't tell just by looking at what's happened. You either have to get additional information from the problem, or you have to go through the answer choices and kind of just rule them out, okay, which we'll look at here in a second. Okay, so any questions on the cardiac function curve? I promise the vascular function curve goes quicker. No? Okay. So looking at the vascular function curve, it's a little bit simpler. So it can be shifted by two things, and its slope is only affected by one. So what two things shift the vascular function curve?
Blood volume and venous tone.
Yep, exactly. Blood volume. And so if I'm hemorrhaging, or if I'm like getting overhydrated by an IV, so those shift it. And venous compliance will also shift it. So venous constriction or relaxation, we'll talk about, well, that really kind of ties in with that first one a little bit. We'll talk about why here in just a second. And then what is the only thing that affects the slope of the vascular function curve?
TPR.
TPR, absolutely. And remember, we said that it has an independent effect on both the cardiac function curve and the vascular function curve. And so not particularly super important to answering questions, but just kind of something that they could just kind of throw you like a random ball on. So CV, so the X and Y axes are kind of flipped for the vascular function curve in order to make it coincide correctly with the cardiac function curve. So the dependent variable for the vascular function curve is actually on the X axis. Normally you'd see it on the Y, right? And the independent variable is the Y axis. So cardiac output is actually the independent variable for vascular function curve, and central venous pressure is actually the dependent variable. Not really super important to anything, but Dr. Presley likes to make a point of that. So, okay, so when we're looking at the vascular function curve, there's a few points that you kind of need to know the significance of. So the first one is right here. So where it flattens out and intersects the y-axis, what does that represent technically?
That's when the veins will end up collapsing.
That is correct when we're looking at it this way, which will be my next question. So hang on to that. But where it intersects the y-axis, so this cardiac output here of about 7, what does that represent?
Critical closing pressure.
So the critical closing pressure is the one that's intersects the x-axis. So what this represents, so it would be your maximum cardiac output, right? Theoretically, practically, you wouldn't be able to get that. But so theoretically, what would my maximum cardiac output, what would it be limited by, assuming that the heart could accommodate that much blood? What would limit my maximum cardiac output?
Your maximum volume of blood that you can hold.
Boom, yes. So technically, although not practically, the maximum amount of blood that my heart can pump out as a single beat is the maximum amount of blood that I have in my body, right? That's the limiting factor. So this intersection right here, that indicates my total blood volume. And I put in parentheses available. And the reason for that is because when I have changes in venous compliance, let's say I have venous relaxation, really essentially what you can think of it as, it's a little more hemodynamically, it's a little more complicated than this, but for the purposes of the vascular function curve, when I have venous relaxation, you can think of it of I have blood that's kind of pooling in my veins there. And so I'm effectively taking that blood that's pooling out of the circulation. So it's not available to the body. Does that make sense? So effectively, essentially when I have a venous relaxation, I'm kind of in a sense decreasing my blood volume. And so that's the change that I would see when I shift my vascular function curve. Does that make sense? Okay.
Can you explain that again?
Say that,
Yes.
Yeah, can you say
Yes.
that one more time?
Yeah, sure. And I'll show it in the slide too. But so if I picture a normal state, so if I have venous relaxation, basically what's going to happen is I have some blood that's going to kind of pool there in my, let me draw, maybe that might be better. So these are my veins normally, right? Blood's flowing that way. So if I have venous relaxation, what's going to happen to compliance? Am I increasing or decreasing compliance?
Increasing.
I'm increasing compliance. So that means it's going to give more, right? So my veins are kind of going to look more like that, right? They're going to be a little bit more give in them, a little bit more poofy, right? So technically blood is not literally pooling there. Technically what's happening is the blood is spending more time in transit there. So theoretically it's there longer, so to speak, but that's beside the point. For the point of the vascular function curve, you can think of it as I have blood that's pooling in this area right here. So let's say, for the purposes of making this easy math, if I started with a blood volume of 7, and then I have venous relaxation, and so let's say I have 1 liter of blood that's pooling down here, I've effectively taken that blood out of circulation, right? So how much residual blood do I have available to the body if I take 1 out that's pooling right there?
6.
6. Yeah, that one wasn't a trick. Yeah, not a trick question. Yeah, so 6, right? So essentially what I've done when I increase venous relaxation or when I relax or I increase venous compliance, I essentially am taking some of that blood out of circulation. So I've essentially decreased blood volume, which is why when I have venous relaxation, the curve shifts to the left as though I have decreased my blood volume. Does that make sense a little better?
Yes.
If it doesn't work for you to think of it that way, you don't have to think of it that way to get to the right answer. This is just one way to think of it. If it doesn't help you, you don't have to think of it that way. So, okay. So, okay. The next spot that you need to know is this one right here. So what does this X value represent right here?
That's my girl, the critical closing pressure.
There we go. Yes, it is. Yes. Critical closing pressure. And so what does that represent?
That's when the veins will end up collapsing and kind of not
Yes,
returning blood to the heart as well.
Exactly. Exactly. You have to have some blood in the circulation in order to keep the vessels open. And so that's the point at which any pressure less than that is going to cause your vessels to collapse. Exactly. So it makes sense it would be at 0. The reason this is important is because, so let's say I have venous constriction, I'm decreasing compliance, right? So it's going to take more, by the definition of compliance, it's going to take more pressure in order to keep those vessels open, right? So if I were to have venous constriction, then my critical closing pressure may move to somewhere around 2. Does that make sense? I would have, and that's why my curve would shift in that direction, right? Does that make sense? My critical closing pressure would shift with it. Okay. All right.
Sorry, can you say that one more time?
Yeah, of course, yeah. So the critical closing pressure, that's the amount of that's the minimum amount of pressure that has to be present in order to keep my vessels open. And so any fluid, right, it exerts a pressure on the walls of its container just by the virtue of being in a container, right? So I have to have some blood in the vessels in order just to keep them open, otherwise they close. So, and the reason that this is important, it makes sense that normally it'd be at 0, but if I have venous constriction, then I'm increasing that compliance. So it's going to take more pressure to keep those open, right? Because they're stiffer. Does that make sense? They're going to want to collapse more. Yeah. So that's why if I have venous constriction, my curve shifts to the right. And with that, the critical closing pressure will shift to the right. So we would have something kind of like, oh, that's really bad, but we would have something like that where the new critical closing pressure is somewhere like around 2 or something. Does that make sense better?
Yes.
Okay, perfect. All righty. And then the last point that you need to know is this point right here. So where it intersects the x-axis, what does that represent?
Mean systemic pressure.
Yes, mean systemic pressure. Not to be, sorry, I have writing all over it, but not to be confused with mean arterial pressure, which is you calculate, right? Mean systemic pressure is different. And so what does mean systemic pressure represent?
Is it the pressure created by stress volume?
I think, yes, that's, yeah. Yes, I think you said that correctly. Yes. Basically what it is, it's, yes, you're right. It's basically what it is. It's when you have, it's the pressure exerted by the blood just by the virtue of it being present. Because remember how I said that, a fluid exerts a pressure on the walls of its container just by being present. So the blood exerts a pressure on the walls of the vasculature just by being present. And so that's the pressure that's exerted by all of the blood just by being present in the vascular system. Okay. Okay. Yes, I think that's all I wanted to say on this slide. I saw a few things in the chat. Let's see. Compliance with, so okay, so someone wanted me to explain the compliance versus the relaxation. Was that earlier, or are you wanting me to re-explain that again?
Can you go ahead and confirm what I had written as a response?
Yeah, let me see. You're more compliant when you're relaxed. True. The vessel is more like a balloon. Yes. When it's constricted, it's more like a tube. So it's straight. Yes, that is correct what you said. Yes. Mm-hmm. All right, any questions on here before I move on to the next slide?
Is it also kind of fair to say that like compliance is like the opposite of constriction, or not constriction, resistance rather?
Yes. Yes. Because if you're less compliant, or if you're less compliant, you have more resistance. Yes, that is correct. And I think actually mathematically, it is the exact reciprocal.
Yeah.
Me if I'm wrong, but yeah. Okay, any other questions on this one?
So Amanda, if you have increased venous tone, then you have, I just lost my train of thought, but if you have increased venous tone, then you have decreased compliance.
Correct.
Okay.
Mm-hmm. Yep. Any more questions on this one? Okay. So now we're going to talk over them in a little bit more detail. So first we're going to talk about the shifts. They kind of go hand in hand. So we'll talk about changes in blood volume first. So if I have increased blood volume, what's going to happen to my cardiac output and my pressure throughout the circulatory system?
Also increased.
Yeah, they're both going to increase. Pretty straightforward. If I have more blood that I've squeezed in there, remember blood exerts pressure just by being present. So if I have more blood in there, I have more pressure. And then also if I have more blood in there, my heart's pumping out more blood, or otherwise something's going to back up somewhere. So my cardiac output increases. So that one's pretty straightforward. And so the next one is the venous constriction thing. So hopefully it'll make more sense when I explain it this time. If it totally confuses you and you know it better another way, then that's fine. This is a way to help you kind of visualize it, I guess, and qualify it. So I have a decrease in venous constriction. So that's a weird way of saying venous relaxation. So what happens to my compliance if I have venous relaxation?
Increased.
Yes, I get increased venous compliance. And so if I have increased venous compliance, what I've essentially done is I've kind of created more basically kind of like that balloon that Christina or somebody mentioned. So that balloon kind of expands a little bit and it holds on to a little extra blood there. It holds on to that blood a little bit longer. So what the blood flows more slowly through there. So what I've done basically is that pouching, I've kind of taken that out of the picture a little bit. So it's sitting there. Technically, it's not sitting there for longer, it would clot, but you can think of it as sitting there instead of flowing through the system. So I've really kind of decreased my blood volume by having that little out pouching when I venous relax. So if I've decreased my blood volume, what's going to happen to cardiac output and my pressure throughout the cardiovascular system?
Decrease.
It decreases, yeah. If I have less blood that's effectively going through the circulation, then I've decreased pressure throughout, and I'm gonna have decreased cardiac output because there's less blood to pump, right? Does that make sense?
Yes.
Okay, all right.
When you're talking about increased blood volume increases the pressure, does that mean systemic pressure, or is that a different kind of pressure?
So it's actually all pressure. So it definitely will increase mean systemic pressure. That's why you get the shift that way, right? So our mean systemic pressure definitely increased. We can see it on the graph. But also you will have increased blood pressure, increased mean arterial pressure, because if your blood pressure increases, your mean arterial pressure increases as well. So all the pressures across the board will be increased because you've just tried to cram more stuff in there than was there previously. Does that make sense?
Yes.
Okay, cool. All righty. Okay, and so then the last part of this, talking about total peripheral resistance here. So total peripheral resistance, remember I said it has independent effects on the cardiac function curve and independent effects on the vascular function curve. So going back, what's happening at the level of the vessels if I increase TPR?
They're constricting?
So I get constriction of the arterioles. We said according to Pisai's equation, that does what to resistance?
Increases the resistance.
Increases the resistance. And so when I have increased resistance, so now I'm going back to Ohm's law again. Oops, lost my pen. So Ohm's law, we said, we're just going to write it right here. V equals IR. With V being the pressure and I being the cardiac output when we're talking about the circulatory system, and R still being resistance. So I've increased my resistance. Now out of pressure and cardiac output, which of those can the vascular system control? Pressure, absolutely. So cardiac output for the purposes of the vascular function curve is going to remain unchanged because it can't control that. So what has to happen to the pressure if I increase resistance and cardiac output stays the same?
Can you repeat the question?
Yeah. So what is going to happen to my pressure if I increase my resistance here and cardiac output stays the same? What has to happen to pressure?
Increase.
It goes up.
Yeah, it has to increase. Yeah, exactly. So that's what the vascular function curve is going to do. It's going to try to increase the pressure. When we talk about increased pressure in this instance, we're talking about the arterial pressure. So we're going to increase the arterial pressure in order to maintain blood flow. And so how is the vascular function curve going to increase that pressure? Well, so this is kind of where we go back to talking about the shift in blood. So for the purposes of the vascular system, vascular function curve, you can kind of think of all the blood in the body as being in one of three places. It's either going to be in the heart, it's going to be in the arterial system, or it's going to be in the venous system, okay? There's a capillary bed in between there. That's not one of the three places it can be for the purposes of this. So again, this isn't exactly the way it happens. It has to do with the speed at which each blood cell moves through the system, so therefore how much time it's spending in each compartment, right? But to simplify things, because that makes life easier, so you can think of the blood as being in one of these three spots. So remember that blood exerts pressure just by being present. So if I want to increase my arterial pressure, what's an easy way to increase that pressure? To move blood from where?
From venous to arterial side?
Yeah, so and that makes sense, right? So if I increase my arterial pressure, basically you have to have more blood there, or the blood is spending more time there. It kind of bottlenecks there is what's physiologically happening in order to increase that pressure. So if I shift that blood from the venous to the arterial side, then I have less blood over here on the venous side, right? So what's going to happen to venous return and venous pressure?
Decrease?
Yeah, it's going to decrease. If I have less blood over here on the venous side, I have less blood to give back in venous return, and therefore less cardiac output. And the venous pressure is going to decrease because I have less blood there. And that's exactly what we see happening here. We have a decrease in our cardiac output and venous return. And so we also see the slope here has decreased. The reason that we don't see our pressure change is because we also have a simultaneous change in the cardiac function curve. Right? Does all that make sense, or was that,
Can you explain why the pressure doesn't change, but like the slope does change? Because that just still is so confusing to me.
Yes. So on the Guyton diagram you're talking about?
Yes.
Okay. So the reason being, so if we were just looking at, if TPR just affected the vascular function curve, then we would have that change, right? So instead of going from this point right here to this point right here, it would go from here to there, right? If the cardiac function curve didn't change. But TPR also causes a decrease in the cardiac function curve. And so what's happening there is, so even though we have decreased cardiac output, remember we increased our arterial pressure, so we had to move the blood over. So what's happening is, so normally there should be a decrease in that venous pressure, but because our cardiac output has decreased, it kind of allows that blood to back up on the venous system, if that makes sense. So that was a very complicated way of getting there. So let me restate it in a simpler form. So right here, so normally, based on what I just said, we should have decreased venous pressure because we have less blood over here. But the cart is responding to the TPR by decreasing cardiac output, which means that it's not requiring as much blood. So more blood is allowed to stay here to make up for that decreased amount of blood there, because I'm not pulling as much out with my cardiac output. Does that make sense?
A little bit more, yeah.
Okay, so basically it's like, let's say I have a 5-gallon bucket, right? That's my venous system. My venous system is a 5-gallon bucket. So, and let's say I take a 1-gallon scoop out every time. That's my cardiac output, is a 1-gallon scoop. Well, so that's at normal, right? 5-gallon bucket, 1-gallon scoop. But so I'm left with 4 gallons. But let's say that after these changes, so I decrease my venous pressure because I decreased blood there by shifting it over there. So now let's say I have a 4.5-gallon bucket, okay? So if I still had a 1-gallon scoop that I'm taking out, that would decrease it down to 3.5, and I would have that decreased pressure. But my cardiac output is decreased, so I'm only taking a 0.5-gallon scoop out. So I have a 4.5-gallon bucket now, but I'm only taking a 0.5-gallon scoop out, so I'm left with 4 gallons again. Does that make sense?
Yes.
Okay, cool. Alrighty. Any other questions on this slide here? Okay, alrighty. So that's really the end of that. The important thing here to recognize is that there's only one thing that affects the slope of the vascular function curve, and that's TPR. So if I want to see if I have a change in TPR, where can I look to get a definitive answer to that?
the slope of the vascular function curve?
Absolutely. If that slope hasn't changed, I've had no change in TPR. And if it has changed, let's say the vascular function curve, the slope decreased, that means I had a what in TPR if the slope decreased?
Increase.
An increase. So if I have a decreased slope for my vascular function curve, that means TPR increased. But let's say my cardiac function curve had an increase in slope. What does that mean had to have happened?
A huge increase in contractility.
Yeah, something else had to change, either contractility or heart rate, but something else had to change in addition to cancel out and even counteract that TPR change. Does that make sense? Okay, all righty. So, and we'll see that in the question. So the last thing that I want to show y'all here, so I said that the cardiac function curve can shift, and it shifts when you have damage, right? So I just want to talk a little bit about the kind of pathology of why that damage occurs. You might see a question on it, on the test, it won't look this complicated. You might see a very simplified form of this on the test. But just know if you see a shift in the cardiac function curve, you've had some kind of cardiac damage. So just talking through the pathology real quick. So, and this will be the last little slide before we start the questions. So if you're time management right now. So, so if I have damage to the, the heart, what's going to happen to those muscle cells in the heart? Let's say I have a myocardial infarction and we don't get them to the cath lab quickly enough. What's going to happen to that cardiac muscle? Not a trick question.
Necrosis.
Yes, necrosis. And specifically in the heart, we have what's called fibrotic necrosis, which means that as the muscle tissue dies, it becomes kind of scar-like. And so scars, they're tough and they're firm and they don't give much. So what is that going to do to the compliance of the ventricle walls if I have a bunch of fibrotic necrosis going on?
Decrease.
Yeah, it's going to decrease the compliance because it's more stiff, it's more firm. And so if I have this stiff wall, am I going to be able to fill my ventricles as well?
No.
No, I'm not, because with small changes in volume, I have much bigger changes in pressure now. So normally if I only had, say, I don't know, a pressure of, I don't know, 120 with a volume of 500 milliliters. Well, now I might have a pressure of 120 with a volume of only 300 milliliters. So I'm going to get reduced filling of the ventricles. And so what happens then, if nothing else is changed, basically the end result is that I get a decreased cardiac output at the same pressure, right? So at 120 millimeters of mercury, I'm only getting 300 milliliters of output versus 500. So what that represents here, so I went from A, this normal cardiac function curve, to B, where I've dissociated the Frank-Starling law. And so now if you look at the same atrial pressure, so if I draw a line through here, and we're going to pretend it's straight. So with a normal heart, I'd have a cardiac output at an atrial pressure of 4 that's about like 12 or 13, right? But now with this damaged heart, my cardiac output is only like 2 or 3. So what happens then to compensate is, so you can regain a little bit of cardiac function over time, a little bit as the heart compensates. So that's what the shift is right here and moving that way, right? And you can regain a little bit of contractility. You'll increase the heart rate, right, to try to make up for that. So that accounts for that change in slope there. But the big player here is going to be the vascular function curve. And so what's going to happen is I'm going to try to increase that volume, right? And so that's why my curve is shifting. My vascular function curve is shifting to the right because I'm going to try to hold on to fluids. I'm going to try to increase that volume so that I can get my cardiac output back up to what it was previously. But so I might be able to get it back up, the cardiac output, I might be able to get it back up to that 5, but what is the price I pay for getting it back up to that 5?
Increased right atrial pressure?
Yeah, my pressure has gone from like a 0 to now like a 6. And over time, that increased pressure is going to have pathologic changes on the heart. And so at this point right here, what would we call this curve, curve D? What would we call that? What kind of heart failure?
Compensated?
Yeah, absolutely. That would be compensated heart failure. So what that means is things are not functioning properly, but they're getting the job done. And so, but if this phase could compensate heart failure, if it goes long enough without appropriate intervention and treatment, eventually it'll wear out the system because it's not functioning properly, and you'll get decompensated heart failure where your cardiac output does start to drop. Okay, and you'll still be functioning at that higher atrial pressure, except it won't be as efficient. You won't have that cardiac output that you had previously. Does that make sense? Does anybody have any questions on this slide?
Would we see congestive heart failure here because of the increase in right atrial pressure, or no?
Yes, that would be exactly what you'd see here. It'd be congestive heart failure. And yeah, and so because what'll happen is that right atrium will enlarge, you'll get that backup of pressure. So assuming that this was right-sided heart failure, so let's say it was like an infarction of like our RCA, our right coronary artery. So that means we've got, or it could have been like an inferior wall infarction. Anyhow, so if the right ventricle is what is affected, then we'll get a backup in the right atrium. So we'll get right atrial enlargement. But eventually, where is that backup going to go to? So as the right atrium becomes backed up, what's going to be the next thing to back up?
Vena cava?
The vena cava. So that we call that, so our central venous pressure is going to increase. And so what happens when we start getting an increase in central venous pressure? What are some symptoms of that?
Edema?
Yeah, you can get edema. Where?
I think it's usually in the legs.
Yeah, any dependent part of the body, but yeah, so generally for most people, they'll be the legs. So you'll get pedal edema. It can go up pretty high. What else will you get?
Pulmonary edema?
So that would be left-sided heart failure. We'll talk about it in just a second. But so what feeds into, what's a major thing feeding into the vena cava? The what vein?
You get portal hypotension and ascites, right?
Yep, absolutely. So yeah, the hepatic vein, right? Or well, hepatic vein is, yeah, that's down there. But in any case, but yeah, the inferior vena cava, it gets blood from the liver, right? So you'll get the liver, you'll get hepatomegaly because it's going to get engorged with blood. And then yes, that portal vein coming in, you can also get portal hypertension because it's going to get engorged with blood. So you can get varices in certain places. You can get ascites, right? Things like that. Absolutely. What also would you see in the neck?
Jugular vein distension.
Yep. Yep, that absolutely. So you'll see the jugular venous distension. Absolutely. Okay, that's good enough. And then so if it was left-sided heart failure, so like let's say our LAD got blocked off, that's where the MI happened. So so as that left atrium becomes engorged and backed up, what's the next thing that's going to back up there? Someone already said it.
Pulmonary edema.
There you go. Yep. Pulmonary, you can get pulmonary congestion, so pulmonary hypertension and pulmonary edema. Absolutely. And then what's the next thing that's going to happen after the lungs back up if we still haven't fixed this?
Would you get right ventricular hypertrophy?
Yes, you would. And eventually, if that goes untreated, you'll get right-sided heart failure. So absolutely. We call that cor pulmonale when right heart failure occurs secondary to left heart failure. By the way, what's the most common cause of right heart failure? You'll need to know this year, but you'll need to know next year. Most common cause of right-sided heart failure is left-sided heart failure. So for that very reason that we just talked about. Okay, any other questions on this one? Okay, cool. Alrighty, so we'll go into the questions now. I have 10 questions. They should go pretty quickly. I know we're a little over time, a little bit, and I apologize. But so basically the strategy that I have for answering his questions, I don't go through and try to find I don't like go and try to find the right answer. I go and I try to rule out answers because it's a lot easier to rule out incorrect answers with Guyton diagrams than it is to rule things in, okay? So that's how I do it, and I'll show y'all how I do it. So I have some polls that I can launch if y'all would prefer to do it that way, or we could just talk through it individually. What do y'all prefer? Do y'all prefer doing a poll and then talking through it, or just talking through it?
Let's give us like 15, 20 seconds to think about it and then just talk about it.
Okay, all right. So here, what I'll do is I can go ahead, I can launch the poll, then give y'all a few seconds to look at it, like more than a few seconds, I guess. And then we'll go through it, okay? And these are all Dr. Presley styled questions. I pulled these from Dr. Presley's, from his lecture material and whatnot. So should be very representative of what you'll see on the test. I'll give you all about 10 more seconds on this one. Okay, I know that's less time than you would get on the actual exam, but just for the sake of getting y'all out of here, because I don't want to upset anybody by going over. So, which I've already done. So, oh well. Okay, so yeah, y'all did really well. Let's see, I think I can share it. Maybe. Did it share? I think it's shared. Anyhow, so yeah, y'all did really well on this one. So this is how I would approach this problem if this was me going through it. So in the figure, so solid lines are before, dotted line is after. It wants to know what happened. So I would go through and I would say, so A, decreased blood volume. Has there been a change in blood volume?
No.
No, how do you know?
It would have affected the other curve.
Right, you would have seen a shift in your vascular function curve, and there's no shift there. Okay, so decreased contractility, could that have happened?
Yes.
Yes, because decreased contractility, we'd expect to see that decrease in slope in our cardiac function curve, which we saw. So that one is a possibility. Decreased total peripheral resistance. Has there been a change in TPR?
No.
No, how do I know?
Venous curve didn't change the slope on it.
Exactly, no change in the slope of my vascular function curve. Increased heart rate. Could there have potentially been an increase in heart rate?
No.
Not, so it doesn't specify if it's a physiologic or drastic. So assume it means a physiologic unless it specifies a drastic. They'll make sure if an answer choice wants you to know it's a drastic change in heart rate, they'll usually indicate that. They'll indicate that somehow. So we're assuming this means a physiologic increase in heart rate unless specified otherwise. So with that, we would have expected to see an increase in slope. So not that one. Increased mean systemic pressure. Has there been a change in mean systemic pressure?
No.
No, how do you know?
Vascular curve would have moved too.
Exactly. This point right here would have moved and it did not. So that means our answer has to be decreased contractility. Okay. All right. And I know these are a few softballs, but I'm just trying to show you the kind of reasoning behind this. Okay, here's your second one. Okay, give y'all about 10 more seconds. Okay. So y'all did really good again. So going through this one, so again, solid lines before, dotted line after, and it wants to know what happened. So could my heart rate have decreased?
No.
No, because I haven't gotten any change in my cardiac function curve slope. So did my mean systemic pressure decrease?
Yes, because the intersect with X changed.
Absolutely, we had that shift there. So that one can stay. Did my blood volume increase?
No.
No, because what would I have expected to see there?
Left shift.
Right, or well, right.
I mean the right shift, yeah.
Yeah. The opposite way that it shifted, yes. Increased did contractility change?
No. No.
And I would have had a change in slope of my cardiac function curve. And did my TPR change?
No, because there is no change in slope.
Absolutely, I would have had a change in the slope of my vascular function curve. So decreased mean systemic pressure is correct. Alrighty, so now we'll get a little bit more complicated. I didn't share the results with you on that. Y'all did really well. Okay, here's the next one. Give you all about 10 seconds here. Okay. Alrighty. So y'all did pretty well on this one too. So cardiac out. So again, solid before, dotted after. So I want to know what has decreased. Has there been a change in my cardiac output?
No,
No.
the cross sections are the same level.
Correct, absolutely. So I look at my intersection here, and just like you said, both of these points are at the exact same level. So no change in cardiac output. Has there been a change in central venous pressure?
Yes, it increases.
It increased, absolutely, because we moved from this point to this point. So there has been an increase. We've moved from there to there. Okay, so but I'm looking for a decrease, so that one's out. In diastolic volume, has that changed?
Yes, increases too.
Increased. How do you know it increased?
Central venous pressure is in diastolic volume.
Absolutely. So in diastolic pressure can go on this bottom part of the curve here. So that has also increased. Absolutely. Mean systemic pressure, has that changed?
No, the x-intercept is still the same.
Absolutely. Same x-intercept there, so no change here. And then total peripheral resistance, has that changed?
Yes.
Yes, I sure hope so, because it's the only answer choice left. And how did it change?
Decreased.
It decreased. And how do you know that?
It's a clockwise shift.
Yeah, so we had an increase in our slope of our vascular function curve, which means that, I was trying to outline the vascular function curve. So, and if I've increased the slope of my vascular function curve, that means I've decreased TPR, right? So there we go. Okay, next question. There you go. Y'all are doing really well with these. So either I've really helped y'all or y'all really didn't need any help to begin with. So either way, that's good for y'all because you're doing well. Okay, give you about 10 more seconds. Okay, good. Y'all did really well again. So with this one here, so same thing, blue before, green dotted is after. Wants to know this time what there's been an increase in. So in diastolic volume, has that changed?
Yes. Yes.
It increased because we said it can go on the x-axis here. So from going to this point right here to this point right here, it is increased. So that's a good option. Mean systemic pressure, has that changed?
No.
Nope, same x-intercept. Pulse pressure, has that changed? Anybody?
Can we even tell that from this graph?
Yeah, no, you can't. Very good. Yeah, you cannot tell pulse pressure from the graph. How do you get pulse pressure?
Systolic minus diastolic?
Yeah, exactly. It's the difference between your two blood pressure readings, systolic minus diastolic. So yeah, can't tell it from the graph. So that one's automatically out. Stroke volume, has that changed?
No.
No, how do you know?
Because this is the same as the cardiac output.
Yeah, so it's proportional cardiac output, so it can go on this y-axis here, and moving from this point to that point there, no change. So stroke volume has not changed. TPR, has that changed?
Yes, but it decreased.
Yeah. We just decided in the previous question that because the slope increased on our vascular function curve, that means TPR decreased, and we're looking for an increase in something. So in diastolic volume, answer.
I have a question about so I thought pulse pressure, one of the determinants, it was compliance and stroke volume. So if your stroke volume would be increasing, could you assume your pulse pressure is increasing or no?
I do see your point. So no, you can't directly, because you also have to factor in the compliance of the vessels. So you can't, I see your point.
That's okay. I can accept the answer. I was just wondering kind of what.
Okay.
So a lower compliance would mean a increased pulse pressure. So
correct. Yes.
So yeah, so you can't. I mean, even if it was like if it said a decrease in pulse pressure, maybe, in my opinion, I don't know.
Yeah, I see where you could argue that. I don't have a good reason why not, except to tell you that you can't find arterial compliance on this graph because the vascular function curve only shows you venous compliance. So without knowing what the arterial compliance is, you can't make a definitive statement about the pulse pressure. That's the best reason as to why, but.
So there's probably just a lot of compensating factors that you just can't tell.
Yeah. Yeah.
Thank you.
Yeah, no problem. Okay, number 5. They do like arrows on these exams, so expect to see a lot of up, down, no change arrows. Also on your renal exam, you'll see a lot of that. Okay, give you about 10 more seconds here. Okay. Alrighty. So y'all did pretty good on this one too. This one's a little bit more tricky. So dotted is, or solid is before and dotted is after, and it wants to know what has changed in venous tone and arteriolar tone. So let's start with venous tone. So how do we get venous tone from this graph? Where would we look to see what has happened to venous tone?
Vascular function curve.
Good. And what would we look at on the vascular function curve?
Was there venous constriction or venous dilation?
Exactly. And how would we tell if there's been one of those two things?
There's a left shift of the vascular function curves. So
Absolutely.
Yeah.
Absolutely. So we're looking for a shift. And so a leftward shift exactly means that we've had a relaxation. And so relaxation means decreased tone. So we can go through and automatically mark out anything that is not a decreased tone. Okay. So now looking at arteriolar tone, where would we get arteriolar tone from?
Cardiac output.
So cardiac output is affected by arteriolar tone, but cardiac output itself will not tell us if there's been a change in arteriolar tone because there's a lot of factors going into cardiac output.
Cardiac function curve.
So the cardiac function curve would be affected by arteriolar tone, but it can also be affected by contractility and heart rate. So where would we have to look for arteriolar tone? What is
MAP equals cardiac output times TPR, right?
Is it the afterload or something?
So, okay, so on the equation, I don't know for sure about that. You could be right, you could be wrong. I don't know for sure. I apologize. As far as the afterload, yes, arteriolar tone is a measure of afterload, but what is this basically a measure of right here? Arteriolar tone is what? TPR. Huh?
TPR.
TPR, yes. Remember how when we were going through the slides, we were saying that at the level of the vessel, that what's happening is we have arteriolar constriction. That was the point of that. So arteriolar tone is a measure of TPR, right? TPR measures arteriolar tone. Venous tone is measured by shifts, right? So venous constriction, venous relaxation. And then going back to the previous question, we were talking about pulse pressure, arterial tone or arterial compliance, not to be confused with arteriolar, is not present on the Guyton diagram. But arteriolar tone is, and arteriolar tone is a measure of TPR. And so where do we look for changes in TPR?
Slope of vascular function curve.
Slope of the vascular function curve. And has there been a change in the slope of the vascular function curve?
No.
No, there sure hasn't. It's only shifted. So no change on this one. That leaves us with D as our correct answer choice. Does that make sense how we got there? So that's kind of an example of how you need to be aware of why these things show up in the Guyton diagram. So you need to be aware that TPR comes from arteriolar constriction or relaxation, right? So yeah.
Real quickly, can you say why it was no change, arteriolar tone? I know it had to do with TPR. But...
Yeah, exactly. So arteriolar tone is what determines TPR. If I have increased arteriolar tone or arteriolar constriction, I would have increased TPR. And if it decreases, so if I have arteriolar relaxation, then I have decreased TPR. So basically what I'm looking for arteriolar tone, I'm looking for a change in TPR. And to look for a change in TPR, I look at my vascular function curve and look to see if there's been a change in slope. And the slope of this one has not changed in going from solid to dotted. It's only shifted, but no change in slope. So no change in slope equals no change in TPR, which equals no change in arteriolar tone. Is that
yes, gotcha. Thank you.
Yes, no problem. Any other questions on this one?
Can you explain again why we can't just look at cardiac output?
So in order to look at something to see if one variable is the cause of that, you have to know what all the other variables are doing. And with cardiac output, you have TPR that contributes to that. You have contractility that contributes to that. You have heart rate that contributes to that. You have venous relaxation or constriction that contributes to that. And you have blood volume that contributes to that. So I guess theoretically, if you were able to go through each of those 5 things and determine what has happened in each of them, then you could say yes or no, arteriolar tone has been changed. But I don't know if you'd be able to do that, especially given that certain changes can look similar on it. Like you can't for sure tease out an increase in contractility from an increase in heart rate. Does that make sense?
Yeah, I think it makes sense just to know that TPR is more reflective of arteriolar tone than cardiac output is.
Yeah, that's a very good way of putting it. Yes. Any other questions on this one? Okay. So, oops. All right, here is a easier one for you. All right, give you 10 more seconds. Okay, so y'all did really well on this one. So with this one, so basically we increased heart rate from 70 to 100. So assuming nothing else changes, what happens to cardiac output? Increases, yep. Straightforward on this one. Okay, got another one for you. Okay, give you about 10 more seconds. Okay, good. Y'all did good on this one too. So on this one, increasing heart rate from 70 to 160, is that a physiologic or a pathologic increase in heart rate?
Pathologic.
Pathologic. So what's going to happen to my cardiac output if everything else stays the same?
Decrease.
It'll decrease. Yep. There we go. All right. Number 8, we're almost done.
Is it pathologic because like they're really old, so it shouldn't be that high?
Well, it's pathologic. It would be 160 would start to be pathologic probably in any person more or less. But yeah, you could say, okay, how old did I make that patient? Let me go back. Did I give him an age?
You
No.
just said elderly.
Elderly. Yeah, but like you could say, so max heart rate, how do you calculate max heart rate?
220 minus age.
Absolutely. So assuming an elderly patient, let's say that's at least senior citizen, so 65, so 220 minus 65. What's that? That's 155, yeah, maybe. So yeah, so 155 should be the max heart rate. So 160 would be above that. So yeah, you could, but generally a good rule of thumb is about like 140 is where that shift kind of happens. A good rule of thumb. All right, give you 10 more seconds. Actually, I'll give you 10 more because I know I was talking during that time. So. Okay, there we go. So you also did well on this one. So, all right, so blue before, green after. Want to know what happened. So cardiac output. What has happened to cardiac output on my graph?
Stayed the same.
Yes, absolutely, stayed the same. Same level. So that one's out. Decreased contractility. What has happened? Could there have potentially been a decrease in contractility in my graph?
Yes.
Yes, because we have decreased slope of the cardiac function curve, which it would be consistent with a decrease in contractility. That one can stay. Decreased contractility, we already said yes on that one. So TPR, has TPR changed in my graph?
Yes.
Yes, it has. And how has it changed?
Decreased.
Decreased because we had an increase in the slope of our vascular function curve. So that equals a decrease in TPR. So this one looks like a better answer than B. Then preload. Has preload changed on my graph?
It increased.
It is increased, yep. So going from here to there, it is increased because we could put preload on this x-axis if we wanted to. So preload has increased. That one's out. And we already determined that total peripheral resistance has decreased. So that leaves us with C as the one best answer choice. Yeah? Alrighty, number 9. Christina, I think I know what equation you were trying to get at now.
Yeah, this question should reference exactly what I was trying to say, but I think the disconnect was in my head, mean arterial pressure is equal to like gives you reference to vascular tone. And so I guess you can set that straight that it's not equal, or you can't infer that.
Equal to vascular tone.
Because if you have a higher map, then you should have more constricted vessels equating to more tone. So the other question was saying a decrease in map, which is a decrease in tone. So that's why I chose decrease and decrease.
Yeah, I see what you mean. I gotcha. Yeah. So yeah, I see what you mean. So I would say by and large, yes, that's a good rule of thumb, but and so on like your typical patient, that would probably work. But for the purposes of Guyton diagrams, you'd probably want, because there are technically other things that affect mean arterial pressure than just the constriction. Constriction is proportional to it, but other things can affect that. So I would say make sure to go through it like through a way that connects things that can only be affected by one thing, if that makes sense.
So the take home of that is vascular tone determined by TPR.
Arteriolar tone determined by
yes, sorry.
Yeah, no, you're good. Yeah, no, it's just, that's what a lot of Guyton diagrams is technicality of wording and whatnot, unfortunately.
Thank you.
Yeah. Okay, yes, we will end the polling now. Okay, so this one gave us a little bit of grief here. So we want to know mean arterial pressure, if there's been a change. How do I determine mean arterial pressure from this graph?
If there's a change in TPR.
So that was what we were just talking about a little bit. So TPR contributes to mean arterial pressure, but is that the only thing?
Cardiac
Guess
output
not,
plays
since
a
I'm
role
asking the
too.
question. Huh?
But
What were you gonna say?
wouldn't cardiac output play a role too? But here it doesn't change, so it doesn't affect.
Yes, yeah. So technically you would have gotten to the right answer the same way, whoever just talked before Alex. I forgot. But so the way the mathematical Guyton diagram, Dr. Presley way to get to this answer would be to use Ohm's law. So V equals IR, where V again is pressure and I is cardiac output and R is resistance, right? So I'll write a little P under that. I'll write a little CO under that. So mean arterial pressure is not reflected directly anywhere in this graph, right? But we can deduce it because we can qualitatively determine cardiac output and resistance. So cardiac output, can we determine cardiac output from the graph?
Yes.
Yes. So we look at the intersection here. Has there been a change? No. So no change in cardiac output. Resistance, we can determine that from the graph, and we look at what to determine resistance?
TPR.
TPR, yep. And so has there been a change in TPR?
Yes, decreased TPR.
Yes, decreased TPR because the slope of our vascular function curve is increased. So decreased TPR. So if resistance decreases, cardiac output stays the same, what has to happen to pressure?
It goes down.
Yep, has to decrease. So our answer here is yes, there's been a change in mean arterial pressure and it has decreased. Yeah? Any questions on this one? So I would say, so a lot of y'all have, on some of them, have gotten to the answer another way. And if you're sure that works, then I'm not going to tell you not to do it, right? So if you found, I'm not saying, and maybe it does work, I don't know for certain, because that's not the way I do it. That's not the way Dr. Presley does it, but that doesn't mean it's not right. So, but if it consistently gets you the right answer, by all means do it. What I'm just showing you here is this is kind of the mathematical approach to it, and the mathematical approach to it it's going to work because it's how it's derived, if that makes sense. And it's the way that Dr. Presley derived it. So if it works for you and you know it's worked on all the practice questions and stuff, by all means go for it. I'm not telling you not to.
I have a question. I was just going to ask for if it asks you for preload versus venous return. So like for preload, would you look at the intersection point and the x-axis versus for venous return, you look at the intersection points and the y-axis?
Yes, that's exactly right.
Okay.
Mm-hmm.
And also, if you have a clockwise shift of the vasculature curve, is that a increase in venous return?
It depends on what happened to your cardiac function curve, right? So okay. If your cardiac function curve stayed the same, then yes, would correspond to an increase in venous return. But like with this one, where our cardiac function curve has shifted to, now venous return has stayed the same.
Gotcha. Yeah. I think Alan asked me to repeat what I said. Okay. So I was just, what I was asking was, for instead of cardiac output, one of the other variables you could use is venous return. So that would go on the y-axis and you look at the intersection point. So venous return, you'd look at the intersection point based off the y-axis, but on the x-axis, you would look, that's where preload you would look at along with central venous, since the terms are interchangeable. So anyway.
Absolutely, yes, all that is correct. Any other questions on this one? Okay, last question. This one is the grand finale. Here you go. Okay, give you about 10 more seconds. Okay, so you might remember this one from class, but if you're like me, the first time he went through it in class, it didn't fully sink in. So, okay, so we got a group of palace guards. They're instructed to stay in formation. It's a hot, humid day. After 30 minutes, one of them collapses to the ground. And so we want to know which of the following is going to represent the guard's cardiovascular system just before he collapses. So first off, we have to determine, why did he collapse? What change has occurred that caused him to collapse? Why would someone pass out?
You're not getting enough blood to your brain.
Good. So if I'm not getting enough blood to my brain, that's going to cause me to pass out. And so what parameter would you say has changed if I'm not getting enough blood to my brain? What has decreased?
Cardiac output.
Yeah, absolutely. So if I'm not getting enough blood to my brain, that means that either there's an obstruction there, which I don't think he suddenly developed carotid stenosis. So cardiac output has decreased. That's why I'm not getting enough blood to my brain. So first I'm going to go through and I'm going to mark out any answer choice that doesn't have a decreased cardiac output. So A, does that have a decreased cardiac output?
Yes.
Yep, moved from about there to about there, so we'll leave it. B, decreased cardiac output?
No.
Nope, it increased a little bit, went from there to there. So that one's out. C, decreased cardiac output?
Yes.
Yes.
Yep, went from there to about there. So that one stays. D, decreased cardiac output?
No.
Not really, maybe a little bit, but that wouldn't be enough to make the guy pass out. Okay, so now we're gonna have to think about why he passed out, okay? So it's a hot, humid day. So what is probably happening to the blood in his body?
It's being shifted towards the skin to dissipate.
Absolutely. Absolutely. It's being diverted towards the vascular, towards the capillary beds in the skin in an attempt to cool the body. And so if your blood, so this is kind of a little bit similar to what I was talking about with the blood pooling in your in the veins when you have venous relaxation. If the blood is being shifted to the skin, we're kind of taking it out in a sense of the cardiovascular system, the central system. So if that blood is going to my skin, can it be going back to my heart to get pumped to my brain? Well, eventually it will, but is it doing it while it's going to the skin? No, it's not. So what we're looking at then, what we've effectively done then is done what to our blood volume?
Decreased it.
We've decreased it. We've decreased our available blood volume. So what kind of change would that look like on our Guyton diagram if we decrease blood volume?
Left shift of the vascular curve.
Absolutely. So between A and C, which one shows a left shift or any shift at all?
C.
C. Yep. You got that shift there. And so just to kind of account for the other changes that have occurred on this graph. So we do have a slight decrease in TPR because we have a slight increase in TPR because we've decreased the slope a little bit, right? And that makes sense because if our cardiac output is decreasing, what the brain's going to do, it's going to say, hold up, I need more. So it's going to constrict all the peripheral vasculature, all the peripheral arterioles to try to redirect that blood to the brain. So we're going to have an increase in TPR because the brain's going to constrict everything but its own blood supply to try to get that blood back so it doesn't pass out. So that's why we have a slight increase in TPR there, evidenced by a slight decrease in the slope. And then we have a little bit of an increase in our cardiac function curve. That could be due to increased contractility. And the reason it's not very increased is probably because our heart rate has probably pathologically increased at this point. It's increased so much that now it's starting to counteract that increase in contractility. So
what does that leftward shift in central venous pressure mean? One more time.
The leftward shift is going to be the effective decrease in blood volume that we had, because we're redirecting that blood to our skin. So we're kind of taking it out of circulation, so to speak. So we've decreased our blood volume, our available blood volume. So that's what that leftward shift means. And we can also see from the graph, based on the two intersection points, that we have, whoops, I guess the arrow should be this way. We've decreased our central venous pressure, which makes sense. If we're pulling that blood out to the skin, it's not going to be in our venous system, so our venous pressure is going to decrease there. Okay. All right. Any questions on that one? No.
So a leftward shift of the central venous pressure or the x-intercept will always indicate blood's coming out of circulation.
Yes. Yeah.
Okay, thank you.
And that could be in the form of actual like hemorrhage and blood loss. It could be in the form of pooling in the veins because you have venous relaxation. It could be in the form of redirecting that blood to the capillary beds in the skin. Anything that would essentially decrease available blood. What other questions do y'all have on that one? Okay, so.
Sorry, can I ask you?
No, go ahead.
So,
yeah.
For the cardiac output curve, it's like the same idea where you can't look at like cardiac output altogether. You have to look at kind of the sub parts.
Exactly. Mm-hmm. Yeah, because like with this one, you have probably increased contractility and a drastically increased heart rate. So depending on what those are quantitatively, you end up with something that's a slightly increased cardiac function curve. So yeah, you kind of have to look at each thing individually.
Thank you.
Mm-hmm. No problem. This means questions in Icelandic, I think. So if you learned nothing else throughout this entire presentation, you've now learned something. So I'm really sorry it went over. I apologize. That's my nature. I like to talk. So, and I apologize. But I'll stay on until everybody goes off. So in case anybody has any questions they want to ask, I will be here to answer them to the best of my ability. Let me see if there's anything in the chat that anybody said that I need to answer.
Amanda, thank you so much for your time. This is such a great insight. I did have one question about the critical closure. Could you explain that?
Yes. Yeah, the critical closing pressure. Yes, let's go back.
I had not heard that term before this.
Oh, okay. So I think that one, it might be buried in one of Dr. Presley's like little modules that he does online like that you like go and you click through on the answers or whatever. Let's see, let's erase all the ink on here. So the critical closing pressure, what that is so basically it's like, those like the little long balloons that people like make little animals out of like at parties and stuff. So it's like you have one of those and that's your vasculature, right? So if you don't have anything in there, it's just going to be collapsed, right? You have to have some fluid or something in there in order to have it open up so blood can flow. And the way that we increase that pressure so that it can open up is by putting blood in there, because blood exerts a force on the walls of the vasculature just by being present. So the critical closing pressure is the pressure at which if I'm below that, it's going to collapse. So it's kind of weird if you try to think of it like at neutral. So it's easiest to understand if you think of it when there's like, say, venous constriction. So if I have venous constriction, I've right shifted my vascular function curve. So it's going to look something like that. So my intersection here, my critical closing pressure is now at about 2, right? So what that means is even if I have blood in there, if I don't have enough blood in the venous system to at least create 2 millimeters of pressure, those veins are going to collapse because they're constricting, and so you have that extra force. So I'm going to need at least 2 millimeters of mercury's worth of blood in there to keep them open so they can flow. Does that make sense?
Gotcha. Yes, completely.
Okay, perfect. Yeah.
Sorry, do you mind going over number 9 really fast one more time?
Absolutely.
Yeah.
Let's go to there. Oh, number 9. Okay. So on this one, it's here. Let me clear the annotations. So on this one, it's tricky because so mean arterial pressure is not directly reflected in the Guyton diagram. What you have to do is you have to derive it from two things that you know. And so the way you do that is with Ohm's law. So V equals IR. And so the V, that's our pressure. That's what we're looking for. So that's our mean arterial pressure right there, which we don't know and we can't find on the graph. Okay, I, that's going to be our cardiac output, which we can find on the graph. And then R, our resistance, is going to be our total peripheral resistance, which we can also find on the graph. So we don't need to know exact values for these. We just need to know kind of qualitatively, excuse me, where they're headed. So for TPR, we find TPR by looking at the slope, excuse me, of the vascular function curve. So the slope of the vascular function curve has increased. So that means our TPR has decreased because opposite changes. Our cardiac output, we determine by looking at the two intersections, the Y value for those. So those are both at the same Y value. So our cardiac output has not changed. So if we have a decrease in resistance, no change in cardiac output, that means that our mean arterial pressure has to decrease. Does that make sense?
Yes, thank you. So I think I just get tripped up because I always just want to see like cardiac output and I forget to break it down more, but that makes way more sense. Thank you.
Yeah, you're welcome. A lot of this stuff, it's not intuitive. You have to really kind of stick to the mathematics on it, or you get lost in a dark place really quickly, unfortunately.
No, for sure. Thank you so much.
Yeah, no problem. Let's see, I'll go ahead and
Would it be, I'm sorry.
No, you're good.
Would it be not correct, or I guess, is there anywhere on the graph where you could see a direct representation of afterload?
So afterload,
or would that be the same as mean arterial pressure? Sorry.
So afterload equals resistance. That's kind of like the secret that they don't really tell you on the, I don't know why I'm writing that, but I guess I can write that. I'll just finish as I started. But so that's kind of like the secret that they don't ever tell you in class. So afterload is just another way of saying resistance. So afterload equals TPR. I don't know why I wrote that. I'm literally telling it to you. But yeah, so afterload just equals TPR. That's kind of like the big secret.
Okay.
Yeah, afterload
Okay.
same as resistance.
Okay. Thank you so much. This was super helpful.
Good. I'm glad. I'm glad. Let's see. I'm going to stop sharing my screen.
On number 5, could you just explain one more time why we don't?
Oh yeah, sure thing. Let me, I don't know. I should have just kept sharing my screen. Let me go back to it. Number 5.
Sorry, I just I used Ohm's law and I got it wrong, and I still, I know it was explained a couple times, it still didn't stick.
Yeah, no, don't apologize at all. So, okay. So on this one, so Ohm's law doesn't really play a role in this one. This one, the trick to answering it is just knowing what these two things mean on the graph. So venous tone, what does venous tone mean in the graph terms? What value would represent venous tone?
So we would get venous tone from the vascular function curve, and since it's shifted left, I would think that would be relaxation, right?
Correct.
If it decreased, venous tone decreased relaxation.
Yes, exactly. So we have a decreased tone because we had venous relaxation, and we know that because of a left shift. Exactly. So then arteriolar tone. So that what represents arteriolar tone on the graph?
See, I was thinking total peripheral resistance.
And that's correct. So how do I find total peripheral resistance on the graph?
Well, so I noticed that my cardiac output, even though it stays the same from the curves, like the cardiovascular function went up. So it made me want to think that the total peripheral resistance decreased.
Right.
So
So
then I was wanting to say if the total peripheral resistance decreased, it would follow that arterial tone would decrease. So that's why I liked F, but I still I'm missing something.
right. So what you're missing, so remember how I said that like there's 3 different things that play into changes in cardiac function curve slope, right? There's contractility, TPR, and heart rate. So just by looking at this increase in slope, I can't tell for sure which one of those 3 changed.
Okay.
But if I look at the vascular function curve, I can tell for sure if TPR changed, because TPR is the only thing that changes the slope of the vascular function curve. Does that make sense? So I know that if I have a change in the slope of my vascular function curve, whether that's up, down, or no change at all, I know that that directly represents a change in TPR, because only TPR affects the vascular function curve slope.
Okay, so we really don't even need the cardio curve.
No, you really actually don't even need it to solve
Okay.
the problem. You just look at the vascular function curve, the shift represents the venous tone, and then looking at the slope here, there's no change in slope, so no change in arteriolar tone.
Okay. Yeah, I'll have to work on putting that in my brain, but thank you so much. This was
Yeah, no problem. I'm glad it was helpful. All right, do you have something, John? Okay, let me just check the chat real quick. Okay, and John, I'm not sure if you're still there or not, but I'm gonna go ahead and head out. Okay, and you guys are so welcome. I hope it helped.